we are going to finish the yesterday video concerning this mucocele. I don't know if you remember that it was a congenital mucocele of the right frontal sinus, and we start at the end of the day to show this video. And you have here the mucocele. We are in the frontal sinus, and I try to reach this mucocele through the 2A, and in fact it's not really possible, and I'm going to enlarge this neuriform aperture of the frontal sinus. Okay, enlarge medially and anteriorly, because as you can see, it's impossible to introduce correctly the instrument, despite the dedicated instrumentation for the frontal sinus surgery. Okay, so in this case, don't hesitate to change your strategy, because in fact for the patient it's the same postoperative period if you do a draft 2A or 2B. So now this is a draft 2B, and it's easier to introduce the dedicated instrument and to catch the wall of the mucocele, because in fact in this case the objective is not marsupialization, but it's a complete resection like that. Okay, so the enlargement medially and superiorly, allowing to reach all the wall of this mucocele. So this is the end of the movie. To control the complete resection, it remains a piece of sheet. Okay. Okay, and correct. Now the result is obtained. So you can drill some beak of bone, small beak of bone, but the wall of the operative field is almost flat. So, okay, so it is the end of the movie of yesterday. Next, I would like to show you. I think it's in this presentation. Okay, a case of specific case to know the situation which the hemorrhage is possible or not, and three messages. The first one, as I said, and I'm going to speak of this afternoon. As I said yesterday, nasal polyposis is associated with hamartoma. But hamartoma is not specific from nasal polyposis. It's possible to find it in another situation, pathological situations. And it's possible also to have this diagnosis without any other disease. Okay, this is the case in front of you. Okay, because you have both bilateral and symmetric hamartoma in the anterior part of the olfactory cleft, and all sinus cavities are completely normal. So you can observe this particular behavior of the nose to build some tissue. This is the glandular tissue, an hyperplasia of glandular tissue, like a benign tumor, but this is not a tumor, in fact. Okay. It's possible to observe with the nasal polyposis in a triad with asthma and polyposis and aspirin allergy. And in other disease like Chir-Stores disease, of course, this is an eosinophilic process. This is a vascularitis, but in fact, it's possible to find it with tumor, with another disease, whatever. It's in the literature is described with osteoma, neuroblastoma, whatever the situation when the olfaction is disturbed. Okay. Next, as Mrs. Kerimian said yesterday, this is the second message. You need to use the sum curve, the sum diagram, to analyze and to compare the signal between the T1, T2, and T1 Gado wedge-sheet images. So you have here three different cases. Okay. On the left side on the slide, it is systematically a T2 wedge-sheet images. So you have an as signal, an absence of signal. This is not air, because in fact on the CT scan the sphenoid is completely fulfilled by an homogeneous opacities. So this is not the air here, but content of sphenoid with assignal in T2 wedge-sheet image. This is the opposite for the another two cases. As you can see, it is an intermediate signal or an hyposignal. So, because in fact, with the sum curve, you are able to determine almost the diagnosis, and it's very important. Example, in this case, the specific strong hyposignal or an asignal in T2 wedge-sheet images is pathognomonic for an mycosis disease. Okay. In this other case, okay, you have another patient. In T2, you have an hypersignal in the sphenoid. In T1, an hypo, and T1 Gado also an hypo, but you have an enhancement in periphery by the gadolinium. Okay, so you can believe that it is a mucocele, but I advise you to be cautious because this is not a mucocele. This is an arachnoidocele. And if you do marsupialization, you will be exposed to complication like that, because this is not a mucocele, and the mucocele is a seal barrier between the endocranial area and the nose, but the arachnoidocele, of course, not. So this is not a mucocele, but an arachnoidocele. So I advise you to use this curve of sum to analyze the sinus contents and to avoid differential diagnosis in this particular case. Okay, this arachnoidocele was closed by abdominal fat. This is the CT scan 2 months later after closure. Okay, and it's completely different if you analyze this thoroughly mucocele. This is the mucocele here, because you have an hypersignal in T2 and hyposignal in T2 flare, because the difference in both, the CSF is in hypersignal in T2 And in T2 flare, only hypersignal concern the immobile liquid. This is T2 sequence, but in T2 flare, hyposignal concern only the immobile fluid. So if you want to analyze with accuracy this curve, okay, here you have a mucocele because it's concordant. Okay, here you have an oldest mucocele because it's concordant. Here you have another mucocele, but if you apply this diagram for the arachnoid cell, it is not concordant because the hypersignal is too hyper, okay, and the hyposignal is too hypo. Okay, so the arrow is not vertical and concordant with the T2 and T1, but it's a little bit inclined, or not little bit, but systematically inclined. Okay, so don't forget this table to keep in mind the difference of signal with the MRI to analyze the sinus contents. Okay, it was the third message. Next, the second message. The third message is not the inverted papilloma. No. Oh, yes. The third message is this clinical case. This is a man. He is 71 years old. She is a bank employee and a retiree. He was a bank employed, and he is a retiree without any medical history. Okay, he suffered from another obstruction on right side since 6 months, with mild but recurrent epistaxis, always on the same side on the right since 4 weeks. Okay, it's a reason why. Okay, the general physiologist prescribe a CT scan, and you have here the axial slide and the different images. Okay, so there is a tumor, in fact, and we have a particular image. If you compare here the posterior part of the maxillary sinus, here you have an enlargement of the infratemporal fossa on the same side than the tumor compared to the opposite. Okay, and you have a small lysis of the skull base in the anterior part. So, what do you think about this tumor? Is it angiofibroma? This is a man, of course, but this is not the age. He is 71 years old. It may be an adenocarcinoma, but because you are in the posterior part of the olfactory cleft, but in fact, he never walked wood. This is a bank employee and a retiree. It may be neuroblastoma. Why not? An inverted papilloma, but it's not classical. Or mucocele. Why not? So I advise you to prescribe an MRI. And on T1 weight sheet images, you have this signal. This is an intermediate signal, spontaneous intermediate signals. And on T2, you have this intermediate and hypersignal in this tumor. So, as you can see, this is not a mucosal, of course. It's a tumor, okay? And this is not an angiofibroma because the man is too old, okay? It's not possible with 71 years old, okay? But I take the opportunity to stimulate your knowledge. Comment on dit la conscience? The knowledge? Yeah? Because, as you can see, inside the tumor, you see sinuous formation with asanal. Okay? This is not a signal of bone because, as you can see on the CT scan, you haven't any piece of bone inside the tumor. But this is a particular semiology on MRI, which name flow void. In fact, this is pathological vascular structures built by the tumor with rapid flow. So it is, in fact, some tumoral arteries, okay, without any capacity to vasoconstriction, because this is a pathological vessel, of course. And on MRI, due to the speed of blood inside, it's impossible to unplug the signal of the proton due to the rapidity of the flow. So when you add some GADO, okay, you have a very, very strong enhancement with the gadolinium, which is correlated with the flow void inside the tumor. If you want to, of course, if you want to do a biopsy, because this is the job, to identify the nature of the tumor, okay, be cautious because you are going to expose you for very important bleeding, okay? So this is not an undifferentiated carcinoma, sinonasal undifferentiated carcinoma. This is not an neuroendocrine carcinoma. This is not a neuroblastoma. This is not a blastocytoma. In fact, this is a metastasis of kidney cancer. Okay, this is specific for this cancer to produce some sinonasal metastasis, and sometimes you are going to encounter this particular diagnosis. So when I do the biopsy, the man lost 1 liter of blood during 15 minutes. Okay, so keep calm and carry on. So we have 3 sources of very important bleeding in the nose when you have a disease. The first one is the kidney cancer sinonasal metastasis. The second one is, of course, the angiofibroma, but it's not necessary to do a biopsy to identify an angiofibroma. And the third one, this is the osteoblastoma. It's a very, very, very exceptional tumor, but yes, you have here the kidney cancer metastasis, another one, angiofibroma here, and the osteoblastoma. And look, inside the tumor, you have almost oval acinar area. This is not a piece of bone. This is a flow void and a tumoral vessel with a rapid flow, blood flow inside. Okay, this is the flow void. So all of these pathologies need embolization before to do whatever, biopsy or extirpation. Okay, so as you can see here, you have frontal sinus kidney cancer metastasis. Here, an embolization of angiofibroma, and here an osteoblastoma. Okay, so don't forget that you have three source of very, very, very important bleeding. Okay, these three etiologies. And for the ENT surgeon, is often the ENT who is made the diagnosis of the cancer, because most of the time the cancer is not already diagnosed. So this is sometimes a surprise. Okay. Yes, it was the third message. So now we are going to stop my speech 10 minutes, because the third patient is now in the operative room before the induction, during the time of induction of the general anesthesia. So 10 minutes, and after I'm going to show you the next clinical case with the live surgery, which is an sphenocoanal polyp, and I'll show you the CT scan, okay, and the medical history. So 5 minutes, and we continue.